Contraception 2. Progestogen only contraception. Different types. Progestogen only pill, injectables, subdermal implants, intrauterine systems. Mode of action. The major effect is on alteration of the cervical mucus, making it thicker and less penetrable to the sperm. There is a lesser effect on tubal motility and endometrium, making fertilization and implantation less likely. DMPA also suppresses ovulation. The newer desogestrel-based pill Cerazette prevents ovulation in 97% of cycles. The main effect of intrauterine system is through progestogenic effect of endometrial thinning and prevention of implantation. Effectiveness. Older first-generation progestogen-only pills do not prevent ovulation and have to be taken within 3 hours of the same time every day. The newer desogestrel-only pill is anovulant with superior efficacy and a lower window of administration, 12 hours. Failure rates per 100 women. Progesterone-only pills, 0.3. DMPA, 0.3. IUS, 0.2. Implants, 0.05. Indications. Long-acting reversible contraception should be discussed with all women as they have superior efficacy over user-dependent methods. Women with unacceptable side effects from estrogen or contraindications to its use, for example, smokers over the age of 35, migraine with aura sufferers. DMPA can be used short-term to give reliable protection from pregnancy while awaiting interval sterilization or vasectomy to be effective. Safe duration lactation. DMPA and IUS have high rates of amenorrhea and are regularly used in the management of gynecological conditions such as heavy menstrual bleeding, dysmenorrhea and endometriosis. Contraindications. Sensitivity or side effects to progestogens. Pregnancy. Undiagnosed vaginal bleeding, breast cancer. Advantages. Long-acting reversible contraception methods are significantly more reliable than user-dependent methods. DMPA and IUS reduce risk of endometrial cancer. Lighter, shorter, less painful periods. Disadvantages. Irregular bleeding and changes in the bleeding pattern are the major side effects of these methods. There can be a delayed return of fertility after discontinuing DMPA up to 12 months. DMPA use is linked to weight gain. DMPA is associated with small reversible reduction in bone mineral density as a result of hypoestrogenism with long-term treatment. Caution should be used with long-term use in those with additional risk factors for osteoporosis and at the extremes of reproductive age before attainment of peak bone mineral density and during premenopausal decline. Implants and the IUS need to be inserted and removed by a healthcare practitioner with the associated procedural risks. Long-acting reversible contraception. The LARC methods are becoming increasingly important in DSG pills may have potential benefits over traditional POPs because ovulation is inhibited in up to 97% of cycles and they have a 12-hour window for missed pills. Women should be advised that regular pill taking is required for efficacy and to take the pill at a time of the day that will best suit them to promote adherence. Traditional POPs 3 hours, desogestrel POPs 12 hours late. The missed pill should be taken as soon as remembered. If more than one pill has been missed, only one pill should be taken. The next pill should be taken at the usual time. This may mean that 2 pills are taken in one day. Additional contraceptive precautions. Condoms or avoidance of sex are advised for 2 days, 48 hours after restarting the POP. Emergency contraception is indicated if unprotected sexual intercourse occurred after the missed pill and within 48 hours of restarting the POP. Clinical practice as recommended option for women seeking reliable, safe and reversible medium to long-term contraception. In addition, LARCs are being chosen by many women in preference to equally effective but permanent methods of female sterilization and vasectomy. They also provide superior cost effectiveness due to low failure rate and long-term continuation. These methods are used throughout women's productive life with special consideration given to their use at the menarche and menopause. Copper intrauterine devices. Progestogen only intrauterine system. Progestogen only injectable contraceptives. Depo-Provera injectable contraceptive. Progestogen only subdermal implants. Progestogen only subdermal implant. Postpartum contraception. Ovulation can resume as early as 3 to 4 weeks after childbirth in non-breastfeeding women. It is known that at least 50% of the couples will resume sexual activity by 6 weeks postpartum. The WHO recommends an interpregnancy interval of at least 12 months. Increasing the availability of contraception during the postnatal period can allow couples to plan and space future pregnancies accordingly. Traditionally, women would attend their GP to discuss postnatal contraception. However, there is often limited time during this visit to fully discuss options, and for women wishing to commence a LARC method, for example implant, IUD, additional appointments are often required and may be delayed. This can present barriers to women accessing effective contraception at this time, when it may also be a lesser priority for them. Different contraception information has been summarized here for you. Postpartum intrauterine contraception, insertion method and timing. It has been shown to be safe with no observed increase in the risk of uterine perforation, infection or bleeding problems compared to delayed insertion. It is also cost effective. All women receiving PPIUC should attend a review appointment at 4 to 6 weeks after insertion to confirm device placement and trim threads if necessary. Exclusion criteria: pregnancy-specific exclusions, general contraindications to IUD. Other hormonal methods. Progestogen-only methods. All of the currently available progestogen-based methods can be initiated immediately, postpartum, including the pill, injectable, and implant. The duration of use, side effects, and the cautions for use remain unchanged. Women can be reassured that they are no more likely to experience irregular bleeding if these methods are started immediately after childbirth, and all methods are safe for use while breastfeeding. Combined hormonal contraception, or CHC, are the only methods where immediate postpartum initiation is not recommended due to the increased risk of venous thromboembolism at this time. Coagulation factors mostly normalize by 3 weeks postpartum. Therefore, CHC can be initiated at this time in otherwise low-risk non-breastfeeding women. If additional VTE risk factors are present or the woman is breastfeeding, CHC initiation should be delayed until at least 6 weeks. Additional VTE risk factors to consider in postpartum period are smoking, BMI, preeclampsia, immobility, cesarean delivery, postpartum hemorrhage, blood transfusion, non-hormonal methods. Sterilization. Surgical methods of contraception provide a permanent option for couples who have completed their family. There is an increased risk of regret when procedure is performed in close proximity to pregnancy. Women considering sterilization during planned cesarean section should be counseled at least 2 weeks in advance of the procedure. Discussion should include information about risks, failure rate, and available alternatives. Tubal occlusion using Filshie clips and salpingectomy are suitable options for intracesarean sterilization. Salpingectomy offers a slightly lower failure rate, but operating time and blood loss may be higher. Female sterilization is rarely performed immediately after a vaginal birth. Therefore, an interim contraceptive method should be advised for a woman considering this option in the longer term. Barrier methods. Condoms can be initiated anytime postpartum. Women should delay use of female barrier methods such as diaphragm and cervical cap until at least 6 weeks after childbirth. If used prior to pregnancy, a reassessment for size of the device required should be arranged prior to recommencing. Fertility awareness methods, or FAM. These methods rely on psychological indicators of ovulation, such as menstrual pattern, basal temperature, cervical mucus, to identify fertile times of the cycle. Many of these indicators are unreliable during the postpartum period. Therefore, use of this method for contraception should be delayed until regular menstruation resumes. Contraception and breastfeeding. Breastfeeding may be contraceptive if the criteria for lactational amenorrhea method or LAM are met. Exclusive breastfeeding, amenorrhea, within 6 months postpartum. High level of prolactin inhibits estrogen secretion and ovulation at the level of hypothalamic pituitary axis, and LAM is 98% effective if all criteria are met. Efficacy may be reduced if breastfeeding frequency declines or bleeding resumes. Transition to another method should be ensured by 6 months if other contraception has not been used alongside. All progestogen-only contraceptives are safe for use by breastfeeding women, as there is no evidence to suggest a detrimental effect on milk production or infant outcomes. Combined hormonal contraceptives should be avoided in breastfeeding women for first 6 weeks postpartum due to the theoretical concerns on breastfeeding at this time. Both oral methods of emergency contraception are safe for use in postpartum period. Breastfeeding women should be advised to discontinue and express milk for 1 week following administration of ulipristal acetate due to lack of safety data on its presence and effect in breast milk.